Stuck forever. That's the fear, right? You're weeks or months into your knee replacement recovery, and you're wondering if the motion you have right now is all you're ever going to get. Well, that's exactly what we're going to find out today, and more. Because when it comes to knee replacement stiffness, there's a lot of advice floating around. Some of it's true, some of it is completely false, and some of it, somewhere in between. In this video, I'm putting 9 common beliefs about knee replacement stiffness to the test. For each one, I'll tell you whether it's fact, fiction, or somewhere in between. And more importantly, I'll explain why it matters for your recovery. Hi, I'm Dr. George Bounajem, Dr. B for short, and I'm a board-certified orthopedic surgeon who specializes in hip and knee replacements. I've helped thousands of patients navigate questions, fears, and confusion regarding knee replacement recovery. So let's clear some of this up. Ready? Let's dive in. Belief number 1. If I was stiff before surgery, I'm destined to be stiff after. This one's somewhere in between. If you were stiff before surgery, this probably sounds familiar. You're wondering if you were already starting from behind. And honestly, that's a valid concern. Here's the truth. Preoperative range of motion is the single strongest predictor of postoperative range of motion. Studies show a strong correlation. Patients who start with less motion tend to end with less motion. For example, if your knee only bent to about 80 degrees before surgery, it may not be realistic to expect 120 degrees after surgery. Now, here's the good news. Surgery can improve motion, especially if your stiffness was caused by bone spurs or other mechanical blocks that get removed during the procedure. So you're not locked into your preoperative numbers. But the soft tissues around the knee, like tendons and ligaments, also contribute to stiffness. We can't just cut those all out during surgery, so tightness from soft tissues tends to carry over after surgery. Here's the key point. If you started stiff, set realistic expectations, work hard in therapy, and know that improvement is absolutely possible. It might just look a little bit different than someone who started with more motion. But when you make those gains matters. And that's what the next belief is about. Most range of motion gains happen in the first 3 months after surgery. Absolutely true. The first 3 months, and especially the first 6 weeks, are typically where the most improvements in motion happen. It's critical to understand why. This is the window when tissues around the knee are most pliable. Scar tissue is still soft and can be influenced. Wait too long and it hardens, making further gains harder to achieve. Studies consistently show that flexion at 3 months is essentially equal to flexion at 6 months or even 12 months in most patients. Does that mean that nothing happens after 3 months? Not exactly. Some patients see small, gradual improvement with continued activity and stretching. But those big gains, those happen early. This is why your rehabilitation in those first few weeks and months matters so much. It's not about being perfect, it's about being consistent. But how do you know if you're on the right track? That's where the next belief comes in. I need to hit specific milestones by specific deadlines, or my knee replacement failed. This one's somewhere in between. But let me be clear about which part is true and which part isn't. The first part, I need to hit specific milestones by specific deadlines, is partially true. There are benchmarks to keep in mind. Surgeons often like to see at least 90 degrees of flexion within the first few weeks, though the exact timeline varies. If you're significantly behind, like stuck at 70 degrees with no improvement, that's a sign to contact your surgeon. So yes, milestones matter, but there is flexibility. Different people hit them at slightly different points, even during normal recovery. But the "my knee replacement failed" part, that's fiction. Missing a milestone doesn't mean failure. It means closer monitoring, maybe a change in your therapy plan, or maybe an intervention like manipulation under anesthesia, which we'll get to later in the video. Recovery isn't a pass-fail test with rigid deadlines. Some patients hit 90 degrees at week 1. Others don't get there until week 4. Both can end up with excellent outcomes. What matters more than hitting an exact number on an exact day is trajectory. Are you improving? Even slowly? That's generally a good sign. Are you plateaued or going backward? That's when a change may be necessary. So use the benchmarks as guideposts, not as sources of anxiety. But if you are worried, let your surgical team know, and they can help you from there. Now let's get into the exercise and rehab beliefs. If you have been pushing hard and not seeing results, this next one might explain why. I have to push through intense pain or I won't have a good outcome. For most people, fiction. Hear me out on this one. Pain during recovery, and especially during exercises, is to be expected. But excruciating pain and repeatedly pushing yourself to tears, that's just not necessary for most people, and it can actually backfire. When you push too hard, the knee responds with a rush of inflammation. The joint swells, the muscles guard, and by the next day, you may have actually lost motion rather than gained it. Overly aggressive therapy can cause a cycle where the knee actually stiffens up in response to the inflammation from yesterday's torture session. Keeping pain in a low to moderate range is often more effective and helps avoid the inflammation cycle. Now, I know some of you may disagree with labeling this as fiction, and that's totally understandable. Many patients do feel like they had to go through severe pain in order to recover well, and I don't mean to dismiss that. Part of what makes giving exact expectations challenging is the fact that everyone handles pain a little bit differently. What is mild pain to one person might be excruciating pain to another. But the orthopedic community has made huge strides in streamlining knee replacement recovery and pain control, especially in the last several years. Now, you should always listen to your own physical therapist and surgeon over generalized education on YouTube. But most people just don't need to go into severe pain territory on purpose. Consistency and frequency beat intensity. And while we're on the topic of moving your knee, next up is, it's safe to bend my knee right after surgery. This is fact, especially for standard primary knee replacements. Your new knee is designed to bend. Modern knee replacements are built to handle the forces of movement, especially bending. Some patients worry that if they bend too much, they'll damage the implant or dislocate something. This isn't a hip replacement where certain positions may be off limits. True dislocations of a knee replacement are very rare, and they're almost always caused by trauma or a technical issue, not by you doing your heel slides. In fact, bending your knee early and often is exactly what prevents stiffness. Studies show that starting exercise and doing some walking within the first day after surgery helps to speed up recovery. The implant can handle it. It's the patient's job to move it. Now, that doesn't mean going rogue with aggressive movements that your physical therapist hasn't cleared. And under unique circumstances, like knee replacement revision surgery, your surgeon may tell you to temporarily avoid bending it. Follow their guidance. But know that gentle early bending is safe for standard knee replacements, and is even necessary for a good outcome. But what about those machines that bend your knee for you? CPM machines help improve my knee's final range of motion. This is fiction. If you're not familiar, a CPM, or continuous passive motion machine, is a device that slowly bends and straightens your knee for you as you lie on your back. They used to be standard. Patients could spend hours a day hooked up to these things. Here's the truth. Multiple high-quality studies, including a review of over 20 trials, showed that CPM machines provide no significant long-term benefit to range of motion. On average, CPM machines might give you an extra 2 degrees of flexion in the short term. And by 6 to 12 weeks, patients who used CPM and patients who didn't end up with the same motion. Now, CPM machines generally aren't harmful, and some patients do find them soothing. But they're not the magic bullet that some people think they are. What actually works? Active exercises like heel slides, quad sets, and the stationary bike. You doing the work is far more effective than the machine doing the work for you. Now let's talk about what to expect during recovery. And this next one covers something that could turn into an emergency. Swelling and warmth are nothing to worry about. Somewhere in between. And this one needs your attention. Most of the time, this is true. Your knee will be swollen for weeks and, to some extent, months after surgery. That's normal. The surgical trauma causes inflammation, and healing tissues are hotter with extra blood flow. Your entire leg might be puffy for a while. But here's where I need to be direct. Not all swelling is the same. Swelling throughout the leg and gradually improving with time is common. But if you notice your legs suddenly become more swollen, or if pain and tenderness worsen without any clear reason, that could be a blood clot, also known as deep vein thrombosis or DVT. This is a serious problem that requires immediate evaluation, especially because the clot can travel to the lungs and become a life-threatening problem. Here are other red flags to know about. If you have continuous drainage coming from the incision, new redness that's spreading, or any chest pain or shortness of breath, those are signs to contact your surgeon or go to the emergency room right away. Here's the bottom line. Some swelling and warmth are normal and expected. But if those symptoms are heading in the wrong direction, that could mean something more serious. When in doubt, call your surgeon. And speaking of worrying about your recovery, this next belief is one that causes a lot of stress. If I need a manipulation under anesthesia, it means my knee replacement failed. Fiction. Let me clear this up, because some patients are devastated when they hear they might need a manipulation under anesthesia, or what we often call an MUA. An MUA is not a failure, it's a tool. About 4 to 6% of knee replacement patients end up needing one. Under anesthesia, the surgeon gently but firmly bends and straightens the knee to break up scar tissue that is limiting motion. It's a quick procedure, usually just a few minutes, and most patients see immediate improvement. Studies show average gains of about 30 degrees of flexion if it's performed within the first 3 months after surgery. The key factor is timing. MUAs work best when the scar tissue is still soft and pliable. Wait too long, especially past 3 months, and the results are less predictable and complication rates are higher. It's also important to note that right after MUA, physical therapy is extremely important, just like right after surgery. So if your surgeon recommends MUA, it doesn't mean your surgery failed. No one is grading you or your recovery. MUA has been proven to be a safe and effective way to improve motion. But what if you're already past that window? That's our final belief, and it's one of the most important to talk about. 3 months after surgery, nothing can improve. I'm stuck forever. For most people, this is fiction. Here's the one you've been waiting for. If you clicked on this video worrying about being stuck forever, I want you to hear this. It's true that the easiest gains happen in the first 3 months. It's also true that standard physical therapy becomes less effective after that window. But less effective doesn't mean impossible. First, some patients do continue to see gradual improvements, even at 6 to 12 months. Those gains are smaller, but they can still happen. Second, and just as importantly, if your stiffness is severe at 3 months, there are still other options. For example, static progressive and dynamic splints can help. These are like special braces that apply a gentle, prolonged stretch to the knee, slowly stretching out the tight soft tissues that limit motion. Another option is lysis of adhesions, which is a surgical procedure that involves cutting out the scar tissue surrounding the implant. This can be done with minimally invasive surgery called arthroscopy, commonly known as a knee scope, and it's often combined with manipulation under anesthesia for even greater effect. This dual procedure has high success rates in the right patients, even when performed 6 to 12 months after surgery. The point is, if you're stuck, don't give up. Talk to your surgeon. Get evaluated. The path forward might look different than it did the first few months, but there's often something that can be done. So there you have it. 9 common beliefs about knee replacement stiffness put to the test. If there's one theme I hope you take away, it's this. Recovery isn't one size fits all. Some of what you've heard is true, some of it isn't. And a lot of it depends on your specific situation. The best thing you can do is learn what you can, stay consistent with your physical therapy, and communicate closely with your surgical team. You have more control over this than you might think. If you'd like to learn about my top 8 exercises in the first 6 weeks after knee replacement, I'll put my video on that right here. And if you found this helpful, click the like button and consider subscribing for more videos on knee replacement recovery. It also helps other people find this information when they need it. Stay well, and I'll see you in the next video.